Your job as the jury is to listen to the evidence and decide if the man is guilty or innocent of the charges laid against him. Prosecuting today is Peter Baker, Chief Executive of the Men's Health Forum, who will explain man's crimes and will cross-examine our expert witnesses.
He is prone to develop heart disease, on average 10 to 15 years before women. He is twice as likely to develop one of the 10 most common cancers that affect both sexes. And what does man do when he's ill? When he develops symptoms? When he has a lump or a nasty rash or some sort of unpleasant discharge? What does he do when he feels depressed, anxious or stressed out? Does he phone his GP for an appointment? Does he visit his local pharmacist for advice? Does he see a counsellor or therapist? He does not, or rather he waits, and he waits, and then he waits again. He is too proud to admit that he might have a problem, too obsessed with work to take an hour or two off to see the doctor, too convinced that he is actually indestructible. He may lie awake at night and worry, but he will not seek help until he's in pain or convinced there's something seriously wrong. That explains why more women than men develop malignant melanoma, but why more men than women die from malignant melanoma. Members of the jury, you will no doubt hear evidence today from these so-called expert witnesses that man's nasty, short and brutish life is nothing to do with him. You may hear that it's because men have been overlooked, that health services are inadequate, or that even that man can't help the way he was brought up. I put it to you that the problem is much easier to define and much easier to solve. Man gets ill and dies early because, as the charges against him clearly state, he is guilty of not using health services, not taking sufficient care of his health, and in short, of grievous bodily harm against himself. And the solution? Well, that lies in his hands and his hands alone. He must take responsibility for his actions, and he must change his negative behaviours if he wants to enjoy the pleasures of a long and healthy life.
To admit physical weakness as a young man is a pretty difficult thing to do. An 18-year-old doesn't want to talk about his piles and his chlamydia. He doesn't want to talk about the nasty discharge he picked up off next door 3 weeks ago after that nice party. He doesn't want to come and talk to his GP because his GP goes to the pub with his dad. It couldn't be worse. Now, although he knows that the GP is not supposed to talk out of turn, but he's not totally convinced. So blokes won't go and talk to the GP about that. They don't want to be patronised. They don't want to be told that they're fat and they smoke too much and they should cut down on the carling. They don't want to hear about that. They know it really. I mean, my friend's right. They do know it. But they don't want to be told it by some patronising git in a smart suit.
You say that primary care services have not made themselves accessible to men. I find this barely credible. The government, no doubt with your support, may be about to corral GPs into massive polyclinics. But for years there have been GPs and pharmacists on every or virtually every street corner. If men haven't used these difficult to avoid services, how can it be anything other than their own fault?
And the other problem, he can't go on Saturday morning anymore because his user-friendly GPs have closed their surgery Saturday mornings. The last appointment is usually 5 or 5:30. That's when he comes back from work. He can't say to his boss, I need 2 hours off in order to go to the doctor, because his boss isn't very sympathetic. So if he can't go to his GP after 5 o'clock and he can't go to his GP on Saturday, then what's the government to do but to set these polyclinics up, which are at least open 12 hours a day, 7 days a week, to give him a chance at least of getting to a service that might be open when he wants to get there?
When we have been communicating health, well-being, we have been communicating to ourselves. We've been communicating to health professionals. Doctors have been doing doctor speak. Nurses have been doing nurses speak. That kind of speak. And we speak mostly to social class 1. We have not understood the language of other social groups. And therefore, they don't have a chance there is no framework, there is no hook for them to understand the issues. I want to talk briefly about smoking, which we mentioned earlier, about nutrition, about our work with the Food Standards Agency, with Look After Your Lungs, etc. All concrete bits of evidence. With smoking, we do know that if a smoker were to go to quit himself or to go to a GP, the quit rate is about 0 to 3%. If the individual were to go to an NHS quit smoking cessation, the results are about 30% in that kind of region. Our raw male evidence is that when we do it in the workplace, speaking the language our people speak, we get 70%, double that of the NHS. We've been doing interventions on salt with Men's Health Forum and with the Food Standards Agency. And we've learned things, and I will show later on in the feedback from our people, that actually to engage with our people, and we use the word again and again, to engage with our people, we need to understand what works for them, not what the health professionals want to do. It's easy to do a health leaflet, but health leaflets, our people tell us, just go into the bin. We have shown that very die-hard smokers actually change their minds and give up smoking. I'll have a little slide to show that in our health fairs, smoking has reduced by half in the population that we offer the service to within a year. So we have been doing, men do want, and men will listen, and men will engage, and moreover will change behaviors if we allow them to.
Do you consider that the evidence we've heard from you today is first class or second class?
Entirely first class. The work that we are doing now has not been done before, although there are other companies who are also embarking on in the same area doing similar things, companies like Centrica, for instance.
I see. Well, the jury will, of course, be the final arbiter of the quality of your evidence. Royal Mail, like most companies in Britain today, has to find a way to survive and prosper in a very competitive business environment. Shouldn't companies like yours shouldn't you focus on delivering your core business, the service to your customers, which I'm sure you will agree could be improved, rather than diverting resources to doing work that really should be the NHS's business?
Yes, I see where you're coming from. Our work in the last 3 years has been analysed by the London School of Economics. I've set up virtual companies in HWDC and in Plymouth, and we've been doing a health and well-being strategy across the company. And our work has now been validated by the London School of Economics to say that we have saved the company £227 million. Therefore, health is no longer a nice to do. Health is core business. If your people are not with you, if your people are not delivering, then the company is in a bad shape, bad way.
Alan White, Professor of Men's Health. Your Honour, ladies and gentlemen of the jury, you've charged this man with being incompetent about his health, and it is his responsibility for his high rate of premature death and disability. I beg to differ. The wrong person is in the dock. That space should be reserved for the current health service, and indeed, if there is space, it should be housing all those who have made being a man such a problem when it comes to his health. We have heard about the difficulties us men have in accessing services, and we have seen what can be done when those services are made more accessible. We now need to consider what challenges some men face with managing our health, and why it is that we need these changes in the healthcare provision. This will show that services do need to change, and we need to have a different approach to tackling men's health. With regard to long-term conditions, again we have a problem of a man who is not only having to come to terms with his own health, but a body that is not functioning as a man's body should, and also a frightening new world of healthcare. How is he meant to change not only his whole perception of himself as a man, but also become an expert when no services are geared up to help him? Let's consider what he has at present, taking diabetes as an example. Working full-time is not conducive to either keeping your diet, which up to then has been seen as the domain of a woman, and activity levels in balance, or to getting help, advice, or even for getting to outpatient clinics. When they do turn up, most likely they'll be treated as naughty boys for not attending as often as they should, or for having poor control. How can that be turned around? Well, we all know that men use technology. So let's start by improving their access to blood glucose monitors so they can track their own illness both at home and work. Last month, Alan Johnson devoted £31 million to the development of telecare and telehealth, which is focused on remote monitoring and is being trialled for the management of heart failure, diabetes and COPD. Excellent. Excellent for men. But perhaps it should be extended to give them access to telephone outreach support as well, such as being developed by companies such as Clinical Solutions, where problems can be identified earlier and focused guidance can be available when the man needs it, rather than at some distant appointment which he may not be able to attend. We can start to focus health advice to the man such that he becomes aware of other possibilities for health support. As we found with the self-care project, many men had not thought that the pharmacy was a place where they could get help. They didn't know the NHS Direct, either online or via the telephone. The studies I've done across Western Europe and across 44 countries show massive differences between men. And if it was purely biological, we would all fall off the perch at the same rate at the same time. And we don't. This is a cultural issue. And if you look at social class, that reinforces it.
Natasha Freeman, President-elect from the Institution of Occupational Safety and Health. It's a question for Dr. Stout. You did go to great pains to focus on the fact that men are afraid to talk to female doctors and female receptionists. There are more males in the health and safety profession than there are in the medical profession. Do you think there's a role there for them to support, and if so, in what way?
Well, I think there really is, if that's I'm allowed. I think there is a big role actually to be played. I mean, you know, when we talk about delivery of healthcare, of course, we mustn't confine ourselves to doctors and nurses. I mean, we've already mentioned pharmacists. There are many professionals who work in healthcare, and I'm a great believer in a whole new breed of people called healthcare assistants. And there are plenty of safety officers, there's plenty of alternatively trained people who can offer enormous amounts of advice. And in fact, moving away from the traditional doctor-patient relationship may in fact in some cases be extremely beneficial, because men might feel much more comfortable talking to people that they consider more from their own background than they do others.
Dr. Anne Appleton, I'm a medical practitioner now in the pharmaceutical industry with Eli Lilly, but I'm still, and hope always will be, a medical practitioner. And I think, is it not just a pragmatic issue? The barriers to men's health care are pragmatic, and that most men are the major breadwinners. We do have the highest working hours in Europe, and there are practical issues with access to seeing a general practitioner, for instance. And I think we need to work together. We need to work with what we've got. And I applaud Dr. Wang, for instance, simple measures to increase fruit in the workplace, appealing to men's sense of buy one, get one free. I think that's a very practical measure. Well,
that's very wise. I mean, that's absolutely true. And of course, the Health Select Committee, which I'm a member of at the moment, is currently carrying out an inquiry into health inequalities. And Peter Baker was, in fact, in front of us last week, giving a very strong case for the importance of gender equality in healthcare. And that's what we're looking at as a committee. So it's not true to say we're not looking at it. And we haven't missed the boat on the grounds that, you know, the boat hasn't sailed yet, and there's plenty of opportunity to turn things around and put them right. In terms of our Antipodean friend, I think he's absolutely right about what happens to different societies and different groups if you move them. There's a lot of evidence, for example, about what happens to Japanese groups when they move to, for example, America, and they all die extremely young and nastily, whereas if they stay in Japan, they actually have the longest lived race in the world.
My brother, who is now in his 60s, smokes 50 cigarettes a day. He's a member of Mensa, and so he's not an idiot, I assume. He knows the dangers. His wife died last year of lung cancer because she was a smoker. And yet he says, I'm not going to give up. I mean, okay, he's obviously addicted, but he's not going to give up because he says, well, I've got to die of something. So, I mean, how do you reach these people? I mean, joking aside, he knows the dangers. 50 cigarettes a day at 60 is going to kill him. It killed his wife last year. So, I mean, where does the responsibility and any intelligence come into this? And with all the, information in the world, it's not changing anything. So I'd like an expert, maybe one of the doctors, somebody to give some sort of response to that.
Well, I think the main message I would say is it's about not dying of ignorance. I mean, there's nothing wrong with autonomy. People are autonomous, and as long as people exercise their autonomy from a position of informed position, I've got no problem with that. And then people who say, I understand the risks of smoking, and I'm happy to take them because I like smoking, I've got no problem with that. So I say to people, do you want to give up smoking or not? If they say, I love smoking, I live for smoking, smoking's my life, I really enjoy it, and I know the risks, no problem. Carry on. It's what I find is people who, first of all, don't know the risks. And when we did a Mori survey some years ago about nutrition in children, because I wrote a pamphlet for the Fabian Society and did some research on that area, we found that 70% of people didn't actually understand what constituted a healthy diet for their children. It wasn't that they were deliberately feeding their children badly. They actually didn't understand how to construct a properly balanced diet for their children because of lack of knowledge. Now, that's the real crime in this country, lack of knowledge, where people don't understand the importance of health issues. They don't understand that something can be done to put it right. They're fatalistic. They think, oh, well, it's the way it goes, I'm doomed, that's the end of it. That's the bit I really feel sad about.
And Nick, from the Equality and Human Rights Commission, made a very interesting point about inequalities. The Equality and Human Rights Commission, as he will know, is actually charged with enforcing the gender equality duty. And I wonder, Nick, what action the EHRC will be taking to actually make sure that men's health is taken seriously.
So the charges that you are going to answer are that man failed to make use of the available healthcare services, yes or no? Remember the question, failed to make use of the available healthcare services. Those who feel he did fail to make use of them, can we have your hands up? Those who think the opposite. He failed to make use. The next charge against man did not take sufficient care of himself. Those who believe he didn't take sufficient care of himself. And those who think he did take sufficient care of himself.
Nobody at all. Not one.
And finally, that man is guilty of grievous bodily harm to himself. Those of you who think the man in the dock is guilty of this, hands up. And those who think he's not.
Ah, yes, interesting.
Why, thank you. So our man is found guilty on charge 1 and charge 2.